Okay, good afternoon, everybody. My name is Ulysses Burley, and it is my pleasure to present to you all today, Combating Medical Stigma, to have a conversation. I want this to be a conversation. I don't want to really just stand up here and talk to y'all on the impact of bias on research and medicine. I'll talk a bit more about who I am and who I am representing today in a second. This is what I have planned for our time together. I'll introduce to you all the HIV Vaccine Trials Network, or the HVTN. We'll talk a bit about the differences between medical distrust and medical mistrust. And then we'll take a deeper dive into structural inequity in research through a case study on the Tuskegee syphilis study. And then we'll end by talking about the impact of stigma in medicine and in research and the ways in which you can impact destigmatizing medicine and research. And then we'll end with some Q&A. If there's something that bubbles up for you during the presentation, we're an intimate group. Feel free to stop me and we'll pick up where we left off. Sounds good? Awesome. So, the HIV Vaccine Trials Network is an international collaboration of scientists, clinical trial sites, and community representatives working with government and industry in the global search for an HIV vaccine with the goal of speeding the development and testing of HIV vaccine candidates. We are the largest publicly funded clinical trials program on Earth, dedicated to finding an effective HIV vaccine, and we are largely funded by the National Institute of Health. Anybody get a COVID mRNA vaccine? Okay, so you're welcome. So the HVTN rebranded as the COVID-19 Prevention Network during COVID to evaluate and monitor all of the government-sponsored COVID-19 candidates. And so we ran the clinical trials to make sure that they were safe and effective, and we were a part of the rollout for the mRNA candidates. These are our global sites as of this month. HIV and AIDS is our primary priority, and so most of our sites are in sub-Saharan Africa, where the burden of HIV is the greatest, but we have a number of sites in the United States, South America, and in Southeast Asia. Just a little bit about me. I am a physician by primary training, trained in allergy and immunology with expertise in HIV and AIDS. I'm the founder of UB The Cure, which is an organization based out of Chicago that operates at the intersection of faith, health, and human rights. And I serve as the principal investigator of the Faith Initiative at the HIV Vaccine Trials Network, as well as the chair of the U.S. HIV and AIDS Faith Coalition, which hosted a virtual session on HIV and criminalization on this past Tuesday. You might ask, what is a physician doing leading a faith initiative? I'm also a minister, and I didn't feel entirely whole in a clinical setting, which is largely void of faith. And so I created my own lane, and I said that those two things should accompany one another, faith and health, because they do in people's everyday lives. And organizations like the HIV Vaccine Trials Network understand that intersection. And so most of my work is at the intersection of faith and health, but more specifically faith and HIV. I want to get started with this quote. Martin Luther King Jr. probably is the most overquoted person in the history of humanity, but this quote is my favorite of his because it speaks directly to the work that I do. In 1966, Martin Luther King was in Evanston, a suburb right outside of Chicago, at a conference where he was speaking on behalf of freedom fighters in the South who were demanding health care. And before he went up to the stage, the Oshkosh, which was at the time the Northwestern University college paper, asked him to give his thoughts on the situation with the freedom fighters not having health care. And off the cuff, this was his response: of all the forms of inequality, injustice in health is the most shocking and the most inhuman, because it often results in physical death. It's a much longer quote that goes on to say that he sees no other way forward than direct political action to hold our people with power accountable to make sure that everybody has access to health care. When you see this quote, it's probably misquoted oftentimes. It probably says, of all the forms of inequality, injustice in healthcare is the most shocking and the most inhumane. And oftentimes, people, when I point out that the quote that circulates for most folks, that's kind of a victim of telephone. Y'all remember that game, telephone, we used to play in grade school, where somebody started a message, and then by the time you pass it on to all your classmates, it was completely different at the end? Well, that's kind of what's happening with this quote. And people say, well, healthcare versus health, inhumane versus inhuman, those aren't significant changes, but they are. And mostly around the word inhuman and inhumane. When you look at the definitions of inhumane, the opposite of inhumane is having compassion, being kind. It's these qualities that we want people to have. But the opposite of inhuman is not being human. It's something less than human. And that's a significant difference, which is why I always challenge people to make sure that when they quote Dr. King with this quote, that they get the quote right, especially as it relates to people of color, because we've often been relegated to being less than human. And so this is the correct quote. The next time you see it, if you see it says healthcare and inhumane, you raise your hand and you say, Dr. Burley told me that this ain't right. This is what it really says, and this is why it's important. So, one of the major inequalities and injustices in healthcare has led to what has been popularized as medical mistrust. We didn't talk much about medical mistrust until COVID happened, and then it was the buzzword for everybody, and people weaponized this idea of medical mistrust, especially against people of color who had legitimate concerns with the process and the speed for which the COVID-19 vaccines were developed and rolled out, and then the subsequent access or lack thereof for Black and brown communities for that vaccine. And people in majority communities then would say, well, if you don't trust it, you don't deserve it. You don't deserve to have it. And that's because they don't understand the context for which medical mistrust emanates, particularly for people who look like us in this room. And so I think it's an important distinction to make between mistrust versus distrust in terms of validating the very real mistrust that exists. Distrust is the lack of trust or confidence, a feeling that someone or something is not being honest. It's also framed as a suspicion, and it often leads to feeling that one cannot be trusted. Mistrust, on the other hand, is a valid response to a betrayal or having been betrayed. This sense of betrayal within the healthcare system leads to anxiety, anger, or self-doubt. And so I point this out because the mistrust that people of color experience around healthcare is valid. It's valid because there is a litany of history that shows how vulnerable populations have been betrayed by systems, particularly around healthcare. And it's this notion of this betrayal, having experienced something that then makes me skeptical of that something moving forward, which is a valid response, is how I want to ground the rest of our conversation. And so we can talk about what some of these medical abuses are, what some of these betrayals are, if you will, throughout history, that very much so validate the medical mistrust that many black and brown communities harbor as it relates to research and healthcare. Anarcha Westcott, anybody knows who Anarcha Westcott was? Come on, HBCU.
Well, in my recollection, she was someone that was experimented on.
That's good.
From like the gynecological sense.
That's real good. Excellent. So Anarcha Westcott and other women were victims. They were experimented on by this man in this picture, who's Dr. J. Marion Sims. He's often called the father of gynecology, or the father of modern gynecology. There are statues erected of him around our country. And he got this moniker as the father of gynecology because he would experiment on the reproductive organs of enslaved black women without their consent and without anesthesia. So he learned everything that you could possibly learn about the female reproductive system as a direct result of trauma against these black women. And Anarcha Westcott was one of them. There were others. And so when I talk about this story, I like to center the women who contributed to gynecology as the mothers of gynecology, rather than highlighting Dr. J. Marion Sims as this pioneer in gynecological medicine because of how he got that moniker. And because of protests, mainly by black women, some of the statues that have been erected of him around our countries have been relocated. There was one such statue of him in Central Park, and I think in 2018, after much protest by black women, that statue was removed from Central Park and it was relocated to the cemetery where Dr. J. Marion Sims is buried in Brooklyn. It's not currently on display, it's in a storage facility, but that was one of the effects of the advocacy of people knowing their history and then saying that you're not gonna keep playing in my face every time I'm running in Central Park where I got to run by this guy who brutalized my ancestors, and we celebrate him for it. And then there was Henrietta Lacks. Everybody know the story of Henrietta Lacks. It's more public. There's been books, there's been movies. Just up the road at Johns Hopkins in Baltimore, Maryland, Henrietta Lacks went in and she had cancer. And one of the physicians took samples of her tumor without her knowledge and then went and used those cells for research in a laboratory. And in doing so, he realized that her cells survived outside of the body in a way that no other cell line had survived previously. And so it was a breakthrough, meaning that, my goodness, we can replicate these cells. That means we can use them for research. When I was in my training in school, I used HeLa cells, is what we call them, in cancer research. And all kinds of things have been developed as a function of Henrietta Lacks' unknown contribution to cell biology. The polio vaccine that exists was developed using HeLa cells. There are a number of different other treatments that have been developed, cancer research that's done with HeLa cells. And her family didn't even know for a long time. And then once they discovered it, didn't reap any of the benefits from this discovery until within the last 5 years. They settled for an undisclosed amount, the family did, for their ancestors' contribution. But again, this was somebody who went into a healthcare setting because they were suffering from a legitimate medical issue, cancer, and they were exploited in that setting. And then people were able to benefit from it and profit from it. All kinds of lives have been impacted as a result of this cell line, which is a great thing, but it was absent of her consent, and it was absent of compensation for her contribution to cell biology. And then there's one that might be less known. We know who Fannie Lou Hamer was. She was a civil rights icon. She was a senator, a politician. But what you might not know is Fannie Lou Hamer went into a Mississippi hospital with pain in her right side. And it was later discovered that she had appendicitis. Her appendix was inflamed. And so they had to give her an appendectomy, remove her appendix. Little did she know later on, when she left, she discovered that not only did they remove her appendix, but they also removed her uterus. They gave her a hysterectomy while she was under, without her recollection or without her consent. And this was happening all over the South. It was happening in Afro-Caribbean countries where women were being sterilized. Unbeknownst to them, they would go into healthcare settings with routine issues, and they would leave missing their uterus, which, apart from not being able to bear children, has a host of other consequences for women. And so it became so common that they were deemed as the Mississippi appendectomies, where black and brown women were going into healthcare settings and for one thing and would leave with another. And then there's something that maybe is more proximal to our experience today. Anybody know who Margaret Sanger is? Anybody know who Planned Parenthood is? Okay. So we like Planned Parenthood. Planned Parenthood provides health care, particularly for women at subsidized cost. It's not a perfect endeavor, but they have allowed for many people, many families to access health care. But its founder, Margaret Sanger, who is largely celebrated as the mother of reproductive justice. She was the primary activist behind the birth control pill. So the birth control pill would not exist today without the activism of Margaret Sanger. She was a feminist. She was a women's rights champion. But she was also a racist eugenicist. Eugenics is this idea that certain people shouldn't reproduce to weed out, if you will, bad traits. And so we don't want poor people making poor babies. We don't want black people making more black babies because they're inferior, so on and so forth. And so how problematic then is it for a feminist, a champion of reproductive justice, the primary advocate for birth control, who said that women should be able to make decisions about their bodies, to also align herself with the eugenics movement, which was inherently racist and medically incorrect. And so Planned Parenthood still gets a lot of flack today because of its founder's legacy, and they spend all kinds of time trying to separate themselves from the legacy of Margaret Sanger. But it was very much so present in African American communities, and this is one quote from Ms. Brown, who was a black social worker, speaking on family planning in 1972. She said, "Negroes don't want children they can't take care of, but we are afraid to trust you when your offered help has so often turned out to be exploitation." The first iterations of birth control pills and intrauterine devices, IUDs, were released in predominantly black communities. again, eugenics. We don't want black people having babies. But it was also a clinical trial, if you will, without consent, without informed consent. If we give these people these things, we can let them test it out, see what goes wrong, and then we can go back to the drawing board, and we'll use people's desire to family plan as a selling point. Here, this is birth control. You can take these pills, and when you decide you're ready to grow your family, you can stop taking them. But really, it was just, let's see how they respond to these things. And so, all of these are historical accounts that happen, that whether or not you're aware of them, help to inform how people interact with research and medicine today, and helps to fuel this continued medical mistrust that often persists in black and brown communities. The thing is, you don't have to go back to 1972 or a century before then to experience medical abuse. Anybody with a black grandmother, I'm sure, has heard a story about medical abuse. Anybody who had COVID-19 5 years ago might have experienced medical abuse. And so racial disparity and implicit bias is still very much so present in our healthcare settings today. And it has been well documented in scientific journals. We know that health inequities experienced by black and indigenous people of color are pervasive. We know that particularly black and American Indian and Alaskan natives have shorter life expectancies than their white peers. It has nothing to do about our race, which is a social construct. We know that there are racial and ethnic disparities in healthcare. All of these things have been well documented in the last 20 to 30 years. We also know that healthcare providers themselves still today contribute to medical bias, which is really a nice way of saying, medical racism. We have documentations that provider levels of bias are at the same level as the general public, which is really scary because we go to school for a really long time to separate ourselves from the general public so that we can give highly specialized care to the general public. So the fact that our bias remains that of the general public in spite of the education that we've received is truly alarming and speaks to just how deeply rooted bias is and can be. We know that providers with stronger implicit bias demonstrate poor patient-provider communications and interactions. Newsflash, we know that higher levels of implicit bias are associated with a lower quality of care, and that implicit attitudes are more often significantly related to patient-provider interactions and health outcomes than the treatment processes themselves. And so imagine, as much as healthcare costs, you go in to see your provider, and your provider's attitude has a more deleterious effect on your health than the actual treatment for whatever it is that you went to see your provider for in the first place. And so we have research, we have data to suggest that higher provider bias is associated with disparities in treatment recommendations, expectations of therapeutic bonds, treatment adherence. Pain management is a huge one, particularly for black people, experiencing empathy in healthcare settings, prophylactic treatments, seeing patients as uncooperative or engaging in riskier health behaviors or being non-compliant. All of these things are things that have been documented within the last decade that patients experience from their own providers, which again don't bode well when we talk about stigma in medical settings. And so I want to take a deeper dive into structural inequity in research in particular, and I want to use perhaps the most famous incident of medical abuse as it relates to black and brown people. If you didn't know anything about Anarcha Westcott or Henrietta Lacks or Fannie Lou Hamer, you know about the Tuskegee study, right? But before we get there, I want to point out this Lancet article, which was published really at the height of COVID-19. Listen, COVID-19 was horrible. It was a once-in-a-generation epidemic. It was something that I read about and never thought that I would actually experience it in my lifetime in the way in which we did. We were in our homes for 2 years. It changed the way we interacted with one another, but it also changed the way we interacted with the healthcare system, and it exposed the implicit and inherent biases within the healthcare system to a point to where people had to start talking about it more. People had to start writing about it and just calling a thing a thing. And up until this point, you've noticed that we've used this term bias. And bias, again, I said, is a polite way of saying racism or discrimination. But folks are starting to actually write that, hey, this is race-related and it's racism. And so this really elegant study from race-based to race-conscious medicine, how anti-racist uprisings call us to act. And it talked about our advocacy, our organizing around the brutalization of black and brown bodies that coincided with a COVID-19 pandemic. And so during these times, we saw the killing of George Floyd and Breonna Taylor and Ahmaud Arbery, who was just outside trying to run, and Tony McDade and countless others. And we looked at that as something that was isolated perhaps from our healthcare experience. Oh, these are people who are being targeted by the state. This is an issue around law enforcement. But concurrently, a similar type of assault was happening within healthcare settings as it related to COVID-19 that ultimately led to black and brown people being disproportionately at risk for COVID-19, having more severe disease when they actually contracted COVID-19, and then weren't able to access the solutions that became available for them because of the color of their skin, where they live, so on and so forth. And so people are starting to finally talk about this, and one of the things that was outlined in this article is kind of this differentiation between where we are, which is race-based medicine, and where we should be, which is race-conscious medicine. And race-based medicine is ill-defined and inferred to have biological significance in terms of the color of one's skin. We're all educated people in here. We know that our skin color is a social construct, that race is a social construct. It doesn't have any implication on our health outcomes apart from the way in which the environment interacts with people of certain colors, which we'll talk about. And so this is the system that we currently exist in. As it relates to research, epidemiological and clinical studies link race with disease. Basic or translational science studies link race with biology. Racial groups are understood as inherently diseased. Biological concepts of race are reinforced. And then there's this healthcare bias and stereotyping that actively takes place that lead to these overarching racial health inequalities. And so this is race-based medicine. This is the system that we have largely existed in. This is where we need to go. Race-conscious medicine, where race is defined as a social and a power construct. That power part is important. And that the effects of structural racism, when analyzed, note the consequences of racism on healthcare, that those things are taught in medical education, and that support is provided to overcome structural barriers to health, which will ultimately lead in a reduction in racial health inequities. And so people are starting to call a thing. They're saying, hey, this is how we've been doing things. This is anti-intellectual for people who claim to be really bright and really brilliant in these spaces. And this is where we need to be going if we are truly answering the oath that many of us took to make sure that people have the greatest access to health and wellness as possible. And so something a work that really lays things out in the context of health and justice or injustice is Harriet Washington's book, Medical Apartheid. This book came out when I was in school in 2006, and almost 20 years later, it's still more relevant than it's ever been. I've learned so much about health equity from this work alone, and people have obviously grown from this body of work. But in Medical Apartheid, Harriet frames structural inequity in terms of research biases in this cyclical pattern, and basically we need to break this cycle, this biased ideas, biased research, biased medical education, biased clinical practice, which then lead to health inequalities across race. And particularly, she explained and unpacked each of these in the context of the Tuskegee experiment, which basically helps us to understand why it went on for so long and why it was as bad as it was. And so we call it the Tuskegee experiment. The actual name is the Tuskegee Study of Untreated Syphilis in the Negro Male. That's a mouthful. And it was conducted by the U.S. Public Health Service. We have to say that because it was government sanctioned. Essentially, it was the hallmark example of medical abuse of black people in the U.S. Men were lied to and told that they were receiving treatment for syphilis, but instead they were prevented from receiving treatment once that treatment became available. And this went on for 40 years, y'all, from 1932 until 1972, with more than 400 poor black men who had syphilis went untreated. And for context, in the work that I do, the HIV epidemic as we know it began just 9 years later. So that's important to note when we think about the deadliest epidemic in our lifetime and in our generation, which still remains to be HIV and AIDS, and how it has disproportionately impacted black and brown people, and how proximal the emergence of that epidemic was to this very fresh, very raw experience with this Tuskegee syphilis study for communities of color. It was almost like it was a perfect storm to then create an environment where this new emerging disease was going to come in and disproportionately impact minoritized communities. And so I just want to take a deeper look of how Harriet Washington really breaks down the ways in which this cycle perpetuated during the Tuskegee syphilis study. First there, you had to start with this bias idea that they believed that syphilis harms black bodies differently than white bodies. They believed that white people were superior intellectually than black people. And because black people had more primitive brains, that the syphilis wouldn't impact their brain because it wasn't much to impact. There's not a whole lot going on up there. And so if white people get syphilis, we believe that it would have neurological effects because white people are so intelligent and they've got a different intellectual capacity than black people. We believe instead that syphilis will impact black people's cardiovascular system. So that's our hypothesis, right? Every research study starts with a question. What do you believe? And based on your study, what do you think the outcome would be? This was their hypothesis. So they started at this place. And so already they started off on the wrong foot. None of this has anything to do with science. It's not rooted in science. It's pure bias. And so they believed that there was a significant difference in how syphilis affected black people and white people, that black people had more primitive nervous systems, and they expected that syphilis would cause more cardiovascular harm in black people as opposed to harming the nervous system in white people. The funny thing about this is not funny, but the thing is, if you state this hypothesis, people who are good at research, if your hypothesis is syphilis will impact the nervous system of white people, syphilis will impact the cardiovascular system of black people, that means you got to test both of those theories in white and black people. Thing is, they only tested the theory in black people. And so, from the start, this was already, apart from the scientific method is what we call it, they were already off track. And so, you make these claims that black bodies are different than white bodies, and therefore syphilis will impact black bodies different than white bodies, but you only tested on black bodies. All right, that's bad research. And so bad ideas, biased ideas lead to biased research, where they observed how untreated syphilis harms black bodies over time, because again, they already believed that there was this difference. And again, researchers did not infect black people with syphilis. That's a key term, because even folks who are aware of the Tuskegee syphilis study, if you ask them what happened, majority of them will say the U.S. government gave black people syphilis. That's not true. These were black people who acquired syphilis in their natural environment, their natural habitat, and then came in expecting to receive treatment for their syphilis, and didn't even know it was syphilis. They called it bad blood. They told them, oh, you got bad blood. And they were denied their treatment, so they were receiving prophylaxis so that researchers could study the progression of it. And again, researchers didn't inform study participants that they had syphilis, nor did they provide them with the cure when one became available, which was penicillin, when it initially came online. So biased ideas lead to biased research, which then lead to biased medical education. Study results published and presented at a medical conference. And so they started here. And no intelligent person stopped to say, well, hold up. If y'all started here, whatever y'all are presenting to me down here is invalid. Because this was a false premise from the first point, because you didn't think, even if you thought that this was true, you didn't think to test the theory out in white bodies the same. And so you start here, you got bad research, and now we pat ourselves on the back and we say, this is what we've discovered. And so now you're educating other researchers, other clinicians, to play into this feedback loop, if you will. And so it perpetuates itself. And so the study results were first presented at the 1936 American Medical Association meeting. This was some 4 years after the first few patients were enrolled. And then biased medical education then leads to biased clinical practice. And so everything that I learned in school was a result of somebody's experimentation, years of research, trial and error, and then science is very black and white. And so it's empirical, it's yes or no, and so this worked, and so this is the thing that we're going to teach future clinicians to do in this situation. And so then that means you've got doctors who are now going to underdiagnose and undertreat syphilis in black patients as a result of really bad research that started here. And as a result of that, you got more black people now who are living with syphilis and who are dying from syphilis because of this false idea that started way over here. Now we have health disparities in communities of color. And still today, black people have a higher likelihood of acquiring syphilis. We're actually in the midst of a syphilis storm, if you will, boom in our country, to where the transmission rates of syphilis are higher than they've been in the last 20 years. And so this is why communities of color have health inequities. It ain't because we black. It's not because we are, our behaviors are different from everybody else. It's because of structural inequity that manifests in research that then translates into medicine and has poor health outcomes for the people on the receiving end of that poor, bad research. And so this is how inequalities exist and how they persist. And then after a period of time, you say a thing so many times, people start to believe it. And then that belief turns into stigma. And so black people are this or black people are that, because all the way back in 1936, we presented this faulty information at this medical conference, and we ran with it. And so one of the ways in which we have to then explore these intersections of inequality and health and research is through understanding the concept of intersectionality, which was coined by Dr. Kimberly Crenshaw. And it refers to the simultaneous experience of categorical and hierarchical classifications like race, class, gender, sexuality, religion, and others. And what are often perceived as disparate forms of oppression like racism, classism, and sexism are mutually dependent and intersecting in nature. And together they compose this unified system of oppression that fuse across all of these dynamics. And so these intersections, when these disparate forms of oppression coalesce into poor health outcomes, we call these the social determinants of health, or the structural determinants and conditions in which people are born, grow, live, work, and age. And so most of this people don't have control over. You're born where you're born, and you end up living where you're living. And as a consequence of that, you know, your economic situation might be one thing, your access to education might be another thing, and likewise your access to health and healthcare might just be predicated on where your parents were when they had you, and what kind of situation your parents were in when they had you. And so for me and my work and the HIV Vaccine Trials Network that particularly focuses on HIV prevention through a safe and effective vaccine and or antibodies, when these social determinants of health impact communities vulnerable to HIV, then it prevents people from, again, acquiring the care and the prevention and the treatment that they need to be healthy and well. And so we call these the bar before the bars. And so this is an HIV prevention cascade. And there's also what we call an HIV treatment cascade. But for the sake of this talk, I want to talk about HIV prevention. And there are people who need to know their status, first and foremost. And depending on what the outcome of their HIV testing is, may or may not need pre-exposure prophylaxis, which is a daily regimen of either pills or a bi-monthly regimen, and even more so a bi-annual regimen of HIV antiretroviral medications that prevent HIV through transmission via sexual contact with almost 100% efficacy. And people don't get here because of stigma, because of racism and poverty and homophobia and transphobia and marginalization and homelessness. And so this is how the social determinants of health intersect with medical conditions like HIV to keep people more vulnerable to disease, to deny them the care and the treatment and the services that they deserve. And it's perpetuated by that provider bias that we talked about at the beginning of our presentation. Because you still have this negative cycle that's feeding into medication, that's feeding into medical education, that's then producing clinicians who are perpetuating that negative cycle. This is an excerpt from an article on how some U.S. doctors are hindering HIV prevention out of San Francisco. And Jake Mason is the patient. And he said he'll never forget the response he received when he asked for a Truvada prescription. Truvada is a form of HIV pre-exposure prophylaxis or HIV prevention for people who are not living with HIV, but who might be more vulnerable to acquiring HIV, preventing them from doing so. He said he asked for a Truvada prescription to prevent HIV at a clinic in Los Angeles. The first thing the doctor said was, "Why do you want to be a cum dumpster?" Mason alleged, adding that he couldn't remember the doctor's name. He said, "Well, I just think you want to be on it so you can sleep with whoever and not use condoms. And I said, first, that's not the reason why. And second, it's none of your damn business. He just said, damn, but I put that in myself. It's none of your business. And Jake left without a prescription. And so it had nothing to do with what he went in there trying to protect himself from possible exposure to a life-altering medical condition. And when he got there, he experienced stigma from his provider, so much so that he left without the very thing that he went to his clinician to receive. And it's not like he can go get it from somewhere else. And so there's this power dynamic as well, right, between provider and between patients. And it's also something that we have to be aware of in understanding how structural oppression intersects to impact people living with HIV and people vulnerable to HIV. It works to intersect with certain identities and behaviors and social conditions that have historically been stigmatized. All of these things here. And so it means that HIV work takes place in the context of historical stigma and oppression. And then we have to consider the cultural dynamics with authority figures, in particular medical personnel. And so we always talk about the relationship between communities of color and law enforcement, and how there's this, authority gap because people who've been empowered by the state have abused their authority in particular communities. But I don't know that we oftentimes consider that there are other persons in authoritative positions that communities of color also view in the same way in a different manner. And so in that last scenario, we talked about Jake going to his provider to seek PrEP. The provider stigmatizes him. Jake leaves without his prescription. Jake didn't get what he needed to. The provider is the gatekeeper there. And so the provider has the power in that situation. And those power dynamics persist throughout communities of color because of instances like this, which then make us less likely to engage the healthcare system because we don't want to be brutalized in another way, if you will, by these authority figures. Even black people who have access to healthcare, we utilize it less than other people who have access to healthcare. So it's not just about people not having healthcare. The system is such that even when I have healthcare, I don't want to use it because I'm going to continue to experience this stigma in a system that I rely on to keep me well. And this system persists throughout clinical trials, which is most relevant to the work that I do with the HIV vaccine trials network. Has anybody ever participated in a clinical trial, clinical research? Yeah, okay, good. So when I was a medical student, I was poor, because all students are poor. And you're always looking for ways to put some little money in your pocket. And so one of the benefits of being at an academic institution is that you got first dibs on all of the clinical trials that were happening on campus. And so I used to sign up for everything because they were going to pay me, they were going to compensate me something. And so I had my heart scanned at some point, brain health, all kinds of stuff. And it wasn't necessarily, even though I was in medical training, it wasn't necessarily because I was like, oh, I want to contribute to medical science. It was like, I'm trying to survive out here. And this is what's most accessible to me. And so it really wasn't until after I was on the other side and my fellowship involved me conducting clinical trials in asthma and flu, particularly asthma in communities of color in and throughout Chicago. And so, we talk about race being a social construct and not having medical implications, and that's true. But the way in which environment and the social determinants of health interact with people of certain racial demographics because of things like redlining and segregation results in poorer health outcomes for those people who have been shut off from resources. And overwhelmingly, we know that black and brown people have much severe health outcomes as it relates to respiratory illnesses like asthma than white people. We also know that the medications that currently exist for asthma prevention don't work as well for black and brown people as they do for white people. And part of the reasons for that is because of the disparity in clinical trials. Listen, the diversity between me and George is less than 0.1%. And so we are more alike than we are different. Despite all of the genetic variations in how we present in the world, we are closely aligned. HIV is way more diverse than the human genome as a disease, and it's one of the reasons why it's been so hard to develop a cure and or a vaccine. But that being said, the environments, there's a thing called epigenetics. And epigenetics is basically the way in which our surrounding environment changes our DNA. And it's real. And so if you have sequestered a certain group of people to a certain environment, a certain way of living for so long, it begins to impact their genetic makeup. And so if you push all black people to live in quote-unquote ghettos that are over-industrialized, that are near the highways, there's standing water everywhere, there's not a whole lot of grass, and there's more concrete than you can name. All these things lead to poor health outcomes. And they lead to this huge disparity in asthma prevalence, as well as the way in which black and brown communities respond to asthma treatment. And so essentially I was doing clinical trials where I was enrolling black people and Latinx communities in and around the Chicago area to test out other novel chronic respiratory medications that weren't approved for asthma. And the outcomes of our study was that these medications were working better for black and brown communities than the traditional studies that were developed for asthma. And again, part of the reason was because majority of the people in the clinical trials weren't those people with these experiences, with these epigenetic changes, if you will, as a result of where they've been forced to live. And so one of the ways in which we have to break out of that negative cycle that we explored from Harriet Washington and the Tuskegee experiment is by erasing the disparity in clinical trials. This is from 2000 until 2020, and basically green represents the total population, blue represents US-based trials by race and ethnicity, and all you need to know is that white people were overrepresented. This is what this means, overrepresented in clinical trials. Black people were underrepresented, Hispanic people underrepresented, Asian people underrepresented, Asian, American Indian, and Alaskan Native overrepresented. Now you might say, 10% representation in clinical trials, we're only 13% of the population, that's pretty close. And you would be fair in saying that. The issue with this representation is we shouldn't base clinical trials disparity on total population. We should base it on representation of whatever it is that we're studying. And so despite the fact that black people only make 13% of the population and overall represent 10% of clinical trial participation, black people are overrepresented in diabetes, HIV and AIDS, asthma, other chronic respiratory illnesses, hypertension, fill in the blank. And so that means that there needs to be an overrepresentation of black and brown communities in those clinical trials, regardless of what our population is. And so that's how we have to start gauging our success in clinical trial enrollment. And we saw an improvement through COVID-19 because for the first time it was truly a situation that impacted all of us. And so people felt more compelled to help us get out of this group project that we were all feeling. And so the COVID-19 clinical trials, which the HPTN as the CoVPN managed, were the most diverse clinical trials to date. But they still weren't diverse enough because our success was based on an overrepresentation of Black and brown communities based on total population, when Black and brown people were widely overrepresented in COVID-19 diagnoses and deaths. And so again, we've got work to do on our end as well, and that means that we have to be more informed about the opportunities of participating in clinical trials, but it means that we also have to have providers who are more trustworthy, who are more community-centered, who actually come from the communities in which they are investigating in. One of the reasons why my fellowship, I was leading clinical trials for communities of color, is because I was the only Black physician in my department at Northwestern Feinberg School of Medicine. And so it was like, all right, we got to do this test on Black and brown people. We guess it's going to be you. And so people felt comfortable coming into my care, and I could identify with their social situation, and it helped for a better experience. I had one of my patients come to my office and propose to me. She was came off hours, and did we not pay you? Did I forget something? And she was like, oh, I just wanted to see if you wanted to get dinner. And I said, no, I don't need to get dinner. I don't need to get dinner because I'm gonna lose my job. But it was community, if you will, and they trusted me, and because they trusted me, I got an accurate patient history that I needed, and we were able to produce positive results that helped us to inform that yes, Black and brown communities need different treatment modalities than the treatments that currently exist. And so we also have to demystify this idea that Black people are less likely to participate in their health and their wellness, because we know that's not true too. And so earlier I talked about how majority communities would weaponize Black people's medical mistrust as it related to COVID-19, saying, well, if you don't trust it, you don't deserve to have it. And because you don't deserve to have it, now that gives me permission to go into your community and get the vaccines that have been designated and prioritized for you. I live on the south side of Chicago, and Chicago is the most segregated city of its size in the country. And so I live where Black people live. And I'm going into Walgreens, and I'm like, where do these white people come from? And you realize that they're there to come and get our COVID-19 vaccine because they couldn't get them wherever they came from. And so, you know, it was a frustrating thing, because it's like, all right, so now it's okay to come to come over here now. Yeah. Because in their mind they said, oh, the Blacks said that they don't trust it. And if they don't trust it, then they don't deserve to have it. It's not true. So post-COVID research suggests that Black people actually were more likely to participate in clinical trials and eventually participate in the COVID-19 vaccine. They just needed more information. And because of our history, because of our legacy, because of everything that we've talked about, we need more information. Tuskegee was the last clinical trial without informed consent. Because of Tuskegee, we now have informed consent in all of our clinical trials today, meaning that a doctor can't come in and take cells from your tumor and then reproduce them without your knowledge, or people can't enroll in a study where they think they're receiving treatment for their bad blood and still be denied their treatment. It can't happen anymore. We've got protections in place as a result of that, but people need more information. People who look like us need more information, and they need it from people who look like them. And so, if there's anything that I want you to take away from this presentation, is that each and every one of you can play a role in combating stigma as it relates to research and medicine. First and foremost, share this information. I think that the Stigma Conference is going to send all of this stuff out and make it available to everybody, but if not, my email is at the end, and you can scan it and I can send it to you. But share this information with other people. But also address stigma and misinformation in your circles of influence. And so all of you have somebody's ear somewhere, whether it's in your house, at your dinner table, or at your church, or in your pickleball community, you have somebody's ear, and you can say, hey, you hear things, and then you have to challenge them. Listen, the black barbershop is one of the it's one of the sanctuaries for black men, but man, it's also could be a sanctuary for misinformation.
Yes.
And so sometimes I just go to the barbershop just to be able to sit up in there and be like, hey man, that ain't true. That's not how that goes. And then they can be like, all right, well we respect you, and so we gonna listen to that. So address stigma and misinformation in your circles of influence. But support research, whether it's HIV research or any kind of research, you know, seek them out. If you live in DC, man, you've got all kinds of academic institutions everywhere. All of those institutions are hosting studies. And I bet wherever you're from, there's somewhere nearby. Just do a search. Clinical research studies near me. And that might just be your contribution for the year. And become community partners. Join a community advisory board. We call them CABs. And CABs are just really important in terms of from the start of a clinical trial all the way to the end. We want to make sure that we have community involvement, but even more than that, community empowerment. And so we're not designing a study and then we're coming to the community and saying,
Yes, I know.
you need to help us implement this, you need to participate in this. At the start of the design, we're asking community to come in and say, all right, you know your community better than we do. Help us design this study such that it's ethical, but it's also accessible for the people who need to participate in it.
In the kitchen.
In the
We no
kitchen.
longer want to be at the table.
That's it.
We want to be in the kitchen.
That's right, making the meal. Host educational sessions in your community or organization. If you all are here, it's because destigmatizing society is important to you. It's also probably because you've got your own level of expertise in areas where stigma persists. And so make sure that you're sharing your expertise in your communities and in your organizations. And join a research study. As of right now, the HIV Vaccine Trials Network is gearing up for its phase 1 studies around broadly neutralizing antibodies, or BNABs. These are antibodies that have been discovered in people living with HIV whose HIV has not progressed without HIV medications. And so their bodies are producing antibodies that control their HIV such that they don't get more sick. And we've identified those antibodies in people, and we've been able to enhance them in a laboratory, expand their life cycle. And now we believe that if we can give these antibodies to people not living with HIV, that it can serve kind of as like a prep that prevents people from acquiring HIV. And it gives people another toolbox in the HIV prevention toolkit that isn't a medication. These are natural antibodies that our bodies made, and we just reproduced them and we gave them back to you. And so there's no adverse reactions. Your body doesn't recognize it as something that's foreign. And so that's what we're working on, and we're going to be gearing up for phase 1 studies for that. Some are enrolling as early as January, but really over the next 2 years we're going to be rolling that out. And so visit helpendhiv.org. We have our red ribbon registry there, and basically you sign up for the registry to say when a study comes available based on the criteria that you entered into that red ribbon registry, we'll flag, oh, this is somebody who could qualify or who might be interested. We'll contact you and we'll talk more about it to see if it's something that you still want to pursue. And just stay informed. Always be seeking information. HIV is a quickly changing landscape, and so that means I'm always having to learn, whether it's just new language or a new class of medications that were just released. And so just stay informed. Always be students in the work that we do together, and advocate and mobilize. That's going to be more important than any of the research work that we do in labs or in clinics, especially across the next 4 years, where people are threatening, the National Institutes of Health and Medicaid and Medicare. We got to have more advocates like those black women that got J. Marion Sims statues removed because they had the information and it didn't sit well with their spirits, and they mobilized and they got changed. I'll leave you with this quote from Dr. Mary Bassett. She says, "Epidemics emerge along the fissures of our society, reflecting not only biology, but more importantly, patterns of marginalization, exclusion, discrimination related to race, gender, sexuality, class, and more. We do little for our patients, but in our context, we're gonna say we do little for people if we fail to recognize these social injustices. I thank you for your time and your attention, and we've got about 20 minutes for Q&A if you all have any. Thank you.
Thank you.
Thank you.
Thank you for this incredible presentation. You know, we have another situation here in Washington DC with our substance use disorder and our overdose crisis that we got going on. And so we see the numbers primarily in our black and brown people that are dying. And it does not mean that the white community is not doing drugs.
Correct.
And that's a very stigmatizing.
Absolutely.
That it is
Yeah.
really across, and we don't know why,
Yeah.
but it's happening.
Yeah. Any questions or comments?
Just a comment about Dr. Mary Bassett. She was health commissioner in New York City just before COVID hit.
Yeah.
And then we lost her.
Yeah.
I think that's one of the reasons why we feel so badly. This coordination between City Hall and Mayor and fighting the health department was just disgusting.
Yeah.
But, so I think she's my personal hero, okay?
Yeah.
She changed the health department from ivory tower
Yeah.
and opened the doors to put Dr. Dimitri Daskalaskis there, openly gay men on the bit of HIV.
Yeah.
He then went to the CDC and then to the president group task force to deal with Mpox, which was another fiasco in
Yes.
New York and everywhere else. But I live in Harlem, and the lines for vaccination for Mpox were mixed with white Latinos and a few black people. I don't understand this. I understand the fact that white people are coming to Harlem to be vaccinated, I understand that. But why were not black